Hey, welcome to my podcast. My name is Dr. Brendan McCarthy. I am the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. We were in Chandler previously, but now we are in Tempe. But during the filming right now, we're in the process of moving. So yeah, I'm changing my, what is it called? The catchphrase when you do that thing, the intro? From Tempe, Arizona. I got to work on the flow of it. Welcome. Thank you for tuning in. We are going to keep talking about PCOS today, and there's so much good information about it. And I love working with this because it's a rewarding thing to work with patients. When you get traction and you move forward with them, you see significant changes in their lives. And so I'm very excited about this next part we're going to discuss today. Before we do, please subscribe. It's right down there. It's one of these links. If you scroll down a tiny bit lower there, you'll see there's a link. Hit that subscribe, and we'll get started. So, previous episodes we've done so far, just in case you have not tuned in, I'm just letting you know we're in the middle of talking about PCOS, Polycystic Ovary Syndrome. We're talking about how it starts, what symptoms people will have. We're talking about different ways I would approach it. Now, I want to let you know this is by no means exhaustive, what I'm doing here. I am by no means trying to tell you that this is the only way or the complete way of treating it. I cannot in a video do that, and you don't want me to. It's important to have a really good, thorough, well-written system of how to treat this in place. My goal in this moment, what I'm trying to do, is discuss certain areas where I've had good success, where I've been able to see changes in my patient's health. And I know these are areas that are not generally practiced in medicine. Just because it's in the book, or just because it's on the protocol, or just because it's considered the standard of care, doesn't mean it's being done that way. Please understand that a lot of times, business is a medicine, and I'm talking from the States. I'm in Arizona, and in the States, medicine is a business, and I'm sure it is around the world too, and it is what it is. With that said, when they look at it from a business perspective, it's like, okay, how do I move the most amount of people through a system and get the most care I can with the best results I can with the least cost I can? So in the odds of it all, if they just have you come in with PCOS and they just do the standard of care, here's your birth control, here's your metformin, and maybe we may use spironolactone or something of that nature, and they send you on your way. That is very profitable in a business model because you come in, they run some basic labs, maybe. Yes, well, generally, they always should run some basic labs. And I'm saying maybe because I've seen people diagnosed with PCOS without a stitch of lab work on them. Just, you got PCOS. That's not good medicine. So you want good lab work. You want those things, but they put you through this box. You get in this box, you come in, your differential diagnosis, this is PCOS. We do the labs. That's what it is. They just write you a prescription for contraceptives, and they write you the prescription for metformin, and they schedule for a follow-up maybe in a year. Sometimes they don't even do that. Sometimes they just keep refilling the prescription and you never go back again and you just keep getting the prescription refilled. That's not medicine. That's not care. That's not thoughtful. It's not intelligent either. I'll say this. You need to stabilize a person. I get that. And I agree with that 100%. And we need to stabilize these people right away. And a lot of times that's the best way to stabilize them. How can I be better than that? That's what the doctor should always ask themselves. How can I be better in this moment? Most physicians work in an environment where they're compensated based upon their volume and based upon following the guidelines given to them by their insurance company or the business that owns where they work, and they follow that. So a lot of times they don't feel they have the luxury of questioning, how can I be better than that? How can I do more in this moment? How can I be a better physician? How can I think around this with this person and be more helpful? I think that's the reason why a lot of doctors have moral injury. Actually, I know it is. There's a ton of research showing that. The physicians, when they feel that they can't fully pursue medical care, they get moral injury, because they know it's right. They know they can do more, but they don't, and they realize they're harming someone by not doing it. So there's that side of it. And then there's the side of it that in previous episodes and in this episode, again, I'll drill down into this. PCOS is a big thing when it comes to fertility. If you treat it right, I've had patients get pregnant. It was a shocking thing in my career in the very beginning. And just by changing diet and lifestyle, they never thought they'd get pregnant. And they got pregnant. So when you're told you have PCOS and you're just put on this simple protocol and not really cared about, how do you feel? I'll talk more about that as we go through the case. So I'm just getting more into it now. So I just want to kind of talk about why we're doing this, what I'm here to do, how I'm trying to be better for you, why I'm trying to do this, what to expect from it. And just take these nuggets to your doctor if you can. And say, what do you think about this? Try and be collaborative with them. Try and reach them on that other level of why they're there to be a doctor. There are many people who are there practicing medicine for the wrong reasons, but there are a lot that are here for the right reasons. They just feel trapped. So you may be that person that helps them break out of it. So in those moments with your doctors, I know some of us, we go in feeling combative and we feel very much like these people are not here to help me because you've had so many bad experiences. And I know it's hard to hear me say, please reach out with an open heart, but there's always the chance you'll meet the one that will do their best to meet you where you are and find you. And so if you can bring some of these ideas to them, and you can start a conversation, maybe we can go in a better direction and things can get better. So PCOS, what the heck's going on? What's going on? Women, you guys don't have a lot of research done about you. And I'm laughing because that's sad and it's heartbreaking. It's actually really sad. Anyway, with PCOS is a big one of them. They don't fully understand it. There's thoughts that PCOS starts because of, you having a genetic predisposition. And I've said this before, I'll say it again. When they throw things in the genetic bucket, that's their way of saying, well, there's nothing we can do about this now. And that's just not good medicine. Even if it is genetic, there's epigenetics. We can do a lot with people with genetics. Just know that. The other reasons why they feel that people have PCOS, environmental triggers. There's talk about how this is mostly due to BPAs in the environment, polychloral PCVs, just different compounds that have an effect on the endocrine system, endocrine disrupting compounds primarily. And that is true, and that is a serious concern. There's ones that they say it's because of lifestyle, that these women brought it upon themselves. This is their culture, this is their home, this is the way they eat, this is their own decisions that brought them there. It's my least favorite. I don't enjoy that conversation. Then there's ones that'll say this is due to, a combination of insults around them, and we don't quite know what that combination is. Why did I say all those things just now? Why did I say all those things? I said them all because if you want to be a good physician, you want to get to the bottom of why someone has something, you need to understand the pathology. How did it start? Where is it going? It's like untying a knot. Basic medicine is seeing a symptom and giving you something to block the symptom, and we're good. That's basic. And that's not good medicine, but stabilizing medicine, okay. Deeper medicine, the deeper thought process goes into how can I unravel this? How can I be better than that? Many of you have been commenting on the previous episodes on the YouTube channel and on the Reels on Instagram, which has been on fire, and I appreciate that feedback from you guys. But if you were just to read through the comments, you'll read a lot of women who have a low glucose, low serum glucose, low hemoglobin A1C, and high insulin. And the frustration they have that when they fast, they don't lose weight. When they do low-calorie diets, they don't lose weight. There's a lot of frustration with women because, the things they're being told to do doesn't work. The reason why is because they're just, how they're being treated, the protocols being given to them are just very superficial, not in depth. So my goal with this today is to talk about in depth and to go to more causative and how we can go down to drill down to the causative component and how these lifestyle changes and supplements and prescriptions can have an impact on you. And then how we verify that. Because again, you guys can go online all you want and say PCOS and nutrients, PCOS and diet, PCOS, and you'll see all these videos, and you'll see all these posts, all these blogs, all these research articles. And what do you do? How do you know what works? Many of them could work, but you don't know. How do you know? Lab work. So the other part of today's conversation with you is how do you test for effectiveness of what I'm talking about? Because that's the thing about my PCOS patients and I, and any of my patients and I write the protocol for you based upon the lab work and our time together and me understanding your case. But I want you to know, every time I write a prescription, every time I write a protocol, anytime I do dietary intervention with my patients, I go back and verify within a short period of time, making sure I see changes in their metrics. It's so frustrating for you to be like, okay, well, I'm going to start taking this supplement. I'm going to take berberine. I'm going to take zinc. I'm going to take chromium. And you're wondering, does this even work? And a lot of you are buying this at a premium price because they're being advertised in such a way. You're like, how can I not buy this? You know? So I want to make sure you understand how we can verify these things work. So if it doesn't work, why are we doing it? Okay, you know? So anyway, what is going on with PCOS and how do I want to unravel it with you today? Let's start off with the idea that PCOS is an issue of insulin resistance. That's a big part of it. Insulin resistance and hyperinsulinemia. So what that means is that the woman will come in and she will have too much insulin. Her fasting insulin will be elevated. And that woman will have insulin resistance, meaning the cells on the surface of the cells, the receptor for insulin, there should be a lot of them, there's diminished or they have diminished function. So now instead of having 10 units of insulin, I'm just making up 10 just for the moment right now, but saying instead of 10 units of insulin, to get the glucose in the cell, you need to use 20 units, 30 units, 40 units. The more and more you become insulin resistant, so the more that cell becomes resistant to insulin, the more your body needs to make insulin in the background. And you build up the insulin because of the insulin resistance. It's a vicious cycle. So these women presenting to clinic with PCOS invariably have excess insulin. That's a very common feature in these cases. And we know it's not just their pancreas just dumping out insulin. We know at the cellular level there is damage to the insulin receptors as well, which is important. This is important. So what happens next? Insulin resistance, high insulin. That insulin is going to now have an impact on the pituitary. Insulin, when it's elevated and it goes to the pituitary, does a few things. Throughout the body, it does a few things. But in the pituitary, it's going to cause irregularities with the way you release these signals from the pituitary that go down to the ovaries. So you see a change with follicle stimulating hormone, which is what initially recruits the follicles that generate estrogen. You're going to see real significant changes in luteinizing hormone, which is what's supposed to cause you to ovulate. You're going to see a change in the way the body responds to feedback from those hormones. So the pituitary, when the insulin hits it and it adjusts or fools around with luteinizing hormone and follicle stimulating hormone, when it blocks that, if you have a thermostat in your house, right, that does dual purpose, say you have one of those houses where you have air conditioning and heat, you know, or the other way around, air conditioning for the high temperature, heat for the low temperature. And your thermostat's a smart thermostat, and it says, okay, if you get too hot, I'm going to turn on the air conditioning. If you get too cold, I'm going to turn on the heater, right? It's like the pituitary is like that. Your pituitary is looking for estrogen and progesterone. Your pituitary is looking for thyroid, looking for all that stuff. And when the person has low levels of estrogen, the body's like, hey, we need some follicle stimulating hormone, okay? And then when estrogen hits a certain high level, the brain's like, we need luteinizing hormone because we need to ovulate. It's time to ovulate. So then the progesterone levels go up and estrogen goes down. So as progesterone levels are high and high up there, and at some point or another, if there was no implantation of the eggs, luteinizing hormone drops off, progesterone drops off, you have a cycle. So your pituitary is that thermostat on your wall that's measuring estrogen and progesterone in this case. When you go there with a lot of insulin, you're basically covering your thermostat with like a washcloth or something. This is an old-fashioned thing you used to do. You want to get the AC to turn up or something, you put a washcloth over it. There's ways of hacking it. So it's like almost, we're sitting there with a blow dryer. You want to get your AC on, put the blow dryer on it. It's like that. You're tricking the system. You're confusing the system. So insulin, when it's elevated, confuses the signals that go to the ovaries that manages the release of these hormones. What happens with that? In PCOS, very specifically, luteinizing hormone, LH, which is supposed to be dominant the second half of the cycle, that's the surge that causes the progesterone, so that's the thing that initiates it. What that does, luteinizing hormone, if it's left high, it's allowed to stay high. It becomes too high. It does a couple other weird things in the body, especially in the ovaries. It's going to stimulate the ovaries to create more androgens. You're going to see elevations in testosterone. You're going to see the total testosterone, the free testosterone elevated. You're going to see dihydrotestosterone elevated. You're also going to see other adrenal androgens be elevated, that's DHEA. And you're going to see something called androstenedione be elevated. These are all androgens. And that's why when women have PCOS, They're going to have that extra levels of testosterone in their body. They're going to have masculinization happening. They're going to have hirsutism, hair growth, maybe some hair loss, oily skin, acne. It's a really stressful thing to experience, especially if it's a young woman. Imagine you're that young woman and you're a teenager, and all of a sudden you're growing hair, you're growing facial hair, you're growing body hair. It's a very stressful thing. And acne as well. In that population, it's a very stressful thing. And stress plays a role in this as well. Because as you have that stress, because of these androgens being higher, the changes in your body, that elevated level of androgens that you have, and that stress from seeing that, and not your identity is being thrown off, like what's going on here? That stress is going to cause your cortisol to become elevated. Fluctuations in cortisol associated with stress like that, we all know cortisol and stress creates weight gain. The mechanism, higher insulin. So insulin steps in again. It's higher. It's higher from the stress of that. So now this girl presenting to clinic has high insulin. She's not ovulating. Her progesterone levels are going to be low because the luteinizing hormone, while it's high, they're not ovulating. And that's a pathway that we can discuss a little bit more in later. But this is where I want to give you kind of a global picture here, how we're going to untie the knot. So they're going to be not ovulating. The progesterone is going to be low. They have estrogen's going to be around all month long. That estrogen all month long is stimulating all the parts of them associated with fertility, the breasts, uterus, cervix, ovaries, body fat, stimulating growth. They're going to have thicker lining of the uterus. They're going to have irregular periods, menorrhagia, which is very heavy periods. They're going to have breast pain, disproportionate weight gain, mood disorders, elevated estrogen unopposed. What does that lead to? Low monoamines. You're not going to have very much serotonin. Low progesterone, what does that lead to? Anxiety. Progesterone plays a huge role in modulating the GABA receptor in women. It's critical. So she's not ovulating. Brain chemistry's off. Estrogen dominant, causing all those physical symptoms we talked about. Neurological and physical, rather. We know that the adrenal androgens are going to be spiked up. The adrenal androgens also go back to the pituitary and fool around with your release rate of FSH-LH. Adrenal androgens and overall androgens do. What else is happening? One other thing that I want to make sure I bring this up to, because it's an important part of our treatment plan, is that when a woman has high insulin, it's going to fool around with her liver's ability to make a protein called sex hormone binding globulin. So sex hormone binding globulin should be at a certain level. And from previous episodes, if you've watched, that's great. You remember me talking about it. But if not, here's some new information. When you have high levels of insulin, it adjusts down the amount of sex hormone binding globulin you make. So your sex hormone binding globulin starts to go down. As sex hormone binding globulin goes down, what sex hormone binding globulin does is a protein in your bloodstream. And when your ovaries make testosterone, or even your adrenal glands, wherever it's coming from, primarily ovaries, testosterone gets bound to that protein. That protein is like a magnet that holds it there, and it renders it inert. So long as testosterone is touching sex hormone binding globulin, it doesn't do anything yet. It is until the testosterone pulls off of that sex hormone binding globulin that's able to touch cells and do its job. So it's like a buffer. So if I diminish the amount of sex hormone binding globulin you have in your body, you're going to have more free testosterone. So your ovaries and your adrenals, the level of testosterone they make, it's going to feel like even more. So you're getting pushed to make more androgens, more testosterone because of this irregularity in luteinizing hormone and insulin. And then the testosterone you do make is going to become even more bioavailable than it was before because of the insulin. This is why it makes this really significant symptoms in this population. It sounds there's hope in here. There's hope in here. Stay with me. There's a lot to cover. There's a lot of, and I, Justin and I spent a lot of time trying to figure out how to deliver you information in ways that you can use. And so I'm going to break this up into a few episodes about treatment. Today is just a little bit of an intro on how I'm going to approach treatment, the things I have in my mind for when I approach my patients. The next episodes, we're going to go more specifically into different aspects, different parts of the person's biochemistry, the woman's biochemistry, where I'm going to be acting and what I think will be the most effective and how I verify. So thank you so much for tuning in. I appreciate this. Your comments, your input, your experiences mean everything to us. I really do read it all. We both do. It's one of those things that it's part of my work that I love to see is people interacting with one another and sharing with each other how they've moved through this. I believe a burden shared is a burden halved. You know what I mean? So if you can share what you're going through, it really helps, and it helps to hear other people how they've gone through it themselves too. You don't feel so alone. So please know your comments have a lot of meaning to us, and that's on the Reels and on the YouTube channel as well. So thank you for tuning in. I'll see you at the next episode.